Hello, friends, and welcome to episode 1259 of the Juicebox Podcast. Courtney is a nurse anesthetist. Oh boy, she's a gas passer. She also has type 1 diabetes, and she was diagnosed at 41 years old. She's now 46. She has Graves' disease and antibodies for Hashimoto's, and today we're going to find out what she sees at her job. Please don't forget that nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan or becoming bold with insulin. Don't forget, if you use my link, drinkag1.com/juicebox, you'll get a free year supply of vitamin D and 5 free travel packs with your first order. And if you go to cozyearth.com and use the offer code JUICEBOX at checkout, you're going to save 30% off of your entire order. Subscribing to the Juicebox Podcast newsletter is this easy. You type juiceboxpodcast.com into a browser, scroll to the bottom, put in your email address, click sign up. I was looking for a way that we could all get nice and tan and meet each other and spend some time talking about diabetes. How are we going to do that? On a juice cruise. Hang out at the end of this episode to learn more. This episode of the Juicebox Podcast is sponsored by Touched by Type 1. This is my favorite diabetes organization, and I'm just asking you to check them out at touchedbytype1.org on Facebook and Instagram. This episode of the Juicebox Podcast is sponsored by the Dexcom G7, the same CGM that my daughter wears. Check it out now at dexcom.com/juicebox. Today's episode is sponsored by Medtronic Diabetes, a company that's bringing together people who are redefining what it means to live with diabetes. Later in this episode, I'll be speaking with Mark. He was diagnosed with type 1 diabetes at 28. He's 47 now. He's going to tell you a little bit about his story. To hear more stories from the Medtronic Champion community or to share your own story, visit medtronicdiabetes.com/juicebox and check out the Medtronic Champion hashtag on social media.
I'm Courtney. I'm a nurse anesthetist, which is an anesthesia provider. And I was diagnosed with type 1 diabetes about 15 years into my career. And I think there's a lot patients can learn to advocate for themselves. And I think as healthcare providers, especially in the perioperative period, there's a lot of finesse to be learned as well. So that's why I'm here.
Cool. So 100% this episode is going to be called Gas Passer, just so you know. And I
love it.
Yeah, it's got to be, right?
I wear it proudly. My coworker actually has a hat that says, I have gas.
Gas Passer, by the way, a phrase I know from the TV show MASH.
I loved that show.
Only way I know that phrase. How old were you when you were diagnosed with type 1?
41 or 29 12 times, I like to say.
Yeah, nice try. How old are you now?
46.
5 years ago. Any type 1 or other autoimmune issues in your family line?
I personally have both that. I had Graves' disease and the antibodies for Hashimoto's as well. So me, and then I have a cousin with Graves, but nobody else with type 1 or other autoimmune that we know of yet.
No celiac?
No celiac.
Here's a weird one for you. Bipolar disorder?
No, not that I know of.
Not that anybody claims out loud. I hear you. No. Okay, great. That's what I want to know. So,
and
go ahead.
Both my kids have done the trial net, which is great and currently negative. And then I just got my sister and all my nieces and nephews to test as well. So,
you're a bit of an anomaly. How about that? Okay.
I know.
So safe to say you were shocked?
Absolutely blown away. So I graduated nursing school. So for those who don't know, a nurse anesthetist has to be a registered nurse first, and then you do ICU experience for a few years, and then you can apply to go back and get your master's. Now it's current. When I went to school as a master's, it's a doctorate now. I was an ICU nurse for 3 years and then a recovery room nurse for a year before I went back to school. And I remember sitting in lecture about our endocrine lecture thinking back in, 99, 2000, thinking, I really don't ever want type 1 diabetes. Like that would be really a nightmare. And granted, the improvement is shocking compared to how we used to treat type 1. But It's, yes, I had knee surgery and got the flu and went into the ER and was shocked to spend a few days in the ICU with a type 1 diagnosis. No idea.
Wow. Knee surgery brought on by an injury or degradation of your knee?
Yeah, I just trying to avoid a knee replacement. I've been really hard on my knees in my lifetime. And at the time when I went to the ER, my A1C was 9.8. So I'd probably been limping towards that diagnosis for at least several months. I'd had a fasting sugar. I got diagnosed in March. In October as part of my annual with a fasting sugar of like 105. So not great, but obviously I wasn't severely impaired at that time. But at diagnosis in full-blown DKA, my blood sugar was only 262. So I think it was the flu just made me so insulin resistant. And I wasn't really eating because I was on crutches like I was.
Courtney, can I ask a question before we get too far past it? Are you some sort of a comic genius?
No.
Did you hear yourself say, I limped towards diagnosis?
I did. Now, yeah.
But you mean after telling me about your knee? And then I was like, oh my God, she's so deadpan when she's doing this. She's either a genius or doesn't know she just said that. Oh my gosh. I would have stopped to congratulate myself for making that joke if I would have said it, just so you know. I would have been like, hey, did everyone hear that?
You're like, I'm so good at this.
Oh my God, I'm so good at this. Did anyone hear that? No. Wow. Okay. So that diagnosis, you're married at that point, I imagine?
Mm-hmm, with 2 kids.
2 kids already. What's your remembrance of the diagnosis time in the hospital stay?
I mean, the first night was a blur. I mean, everybody in DK is sick. I was right along with everybody, extremely sick. Ended up in the ICU for 5 days. I got pneumonia. I had pneumonia, flu A, and I was in this locked knee brace. I was pretty pathetic, like on the unit, like gimping around. I actually missed my son's 6th birthday party because it happened the second day I was in the ICU. And I was like, I can't imagine rescheduling this with everything that is on my plate. So just the grandparents came down and ran the birthday party.
Aww.
But it was all a complete blur.
Yeah.
And I was at the hospital that I work at. So people were coming and going because they were worried. And I really appreciated the visits, but I can't say that I remember who all came.
You know, there was a diabetes educator here once who told me they were diagnosed as a child and had a big birthday party planned for themselves. And the parents didn't have the heart to cancel it because of all the other kids. So he was the only one that didn't go to the birthday party, but they still had.
That's terrible.
He felt it's a nice memory for him. He's like, I thought it was nice of my parents not to ruin it for everybody else.
True.
But my response was yours, Courtney. I was like, oh, that's cold. I was like, yeah, but apparently not. He doesn't remember it that way. Anyway. Okay. So people were in to visit with you. You don't have a lot of memory of it. Do you think it's a blend or a blur of the flu and the diagnosis at the same time?
Yeah. I mean, I'm sure I got, the typical insulin resistance and needed more, I'm sure I have some degree of LADA, right? So that's just a slower onset of type 1. So I'm sure I had some pancreatic function that was keeping me out of DKA until I got the flu. And then it just couldn't.
The rest of it came. Yeah. Well, I'm glad your kids don't have markers. That's terrific news.
Yes. And my sister's a peds ER nurse and she's amazing. And I was calling her from the ER being like, I'm getting sicker and I don't know what's happening. And so she drove down in the middle of the night and was kind of instrumental in helping us through that since she sees a lot of DKA.
How many nurses did your parents make?
Just 2.
Just 2?
100% of their children, but 2.
Oh, it's a hell of a ratio. All right. So you come out of the hospital and, you're now, we're going to jump around a little differently than we usually do in these episodes because of your background. We're going to talk a lot about what you see, as a gas passer. Okay. So you learn about type 1. I heard you say in school, I was like, I don't want that for sure. Isn't that weird that you chose that to say, I don't want that of all the things you were learning about? Right now, we're going to hear from a member of the Medtronic Champion community. This episode of the Juicebox Podcast is sponsored by Medtronic Diabetes. And this is Mark.
I used injections for about 6 months, and then my endocrinologist in the Navy recommended a pump.
How long had you been in the Navy?
8 years up to that point.
I've interviewed a number of people who have been diagnosed during service, and most of the time they're discharged. What happened to you?
I was medically discharged. Yeah, 6 months after my diagnosis.
Was it your goal to stay in the Navy for your whole life, your career?
It was. Yeah. In fact, I think a few months before my diagnosis, my wife and I had that discussion about, staying in for the long term. And, we'd made the decision despite all the hardships and time away from home. That was what we loved the most.
Was the Navy a lifetime goal of yours?
Lifetime goal. I mean, as my earliest childhood memories were flying, being a fighter pilot.
How did your diagnosis impact your lifelong dream?
It was devastating. Everything I had done in life, everything I'd worked up to that point was just taken away in an instant. I was not prepared for that at all.
What does your support system look like?
Friends, your family, caregivers, for me, the Medtronic Champions community, all those resources that are out there help guide the way, but then help keep abreast on, the new things that are coming down the pipe and to give you hope for eventually that we can find a cure.
And you can hear more stories from Medtronic Champions and share your own story at medtronicdiabetes.com/juicebox. You can manage diabetes confidently with the powerfully simple Dexcom G7. Dexcom.com/juicebox. The Dexcom G7 is the CGM that my daughter is wearing. The G7 is a simple CGM system that delivers real-time glucose numbers to your smartphone or smartwatch. The G7 is made for all types of diabetes, type 1 and type 2, but also people experiencing gestational diabetes. The Dexcom G7 can help you spend more time in range, which is proven to lower A1C. The more time you spend in range, the better and healthier you feel. And with the Dexcom Clarity app, you can track your glucose trends, and the app will also provide you with a projected A1C in as little as 2 weeks. If you're looking for clarity around your diabetes, you're looking for Dexcom. Dexcom.com/juicebox. When you use my link, you're supporting the podcast. Dexcom.com/juicebox. Head over there now.
Absolutely. I think about it a lot because sometimes I'll see like our add-on case list and I'm like, I don't want to do that. And it's the second it enters your mind, you're like, yep, that's going to be my case. So now in hindsight, I'm like, I should have never thought that. I should have just embraced the knowledge.
You should have just picked up the daily news, looked at the lottery winners and said, I don't want to be like that.
Exactly.
That definitely would have been the way to go if you were going to jinx yourself, I guess. But now you've got this different understanding, right? Now you're 5 years into it. Let's figure out what your understanding is right now. Like, where's your A1C?
Since diagnosis, the highest A1C I've had is 5.2.
My goodness. Are you eating low carb or are you just very good at diabetes? I
tend to eat lower carb when I'm at work just because I have no time for pre-bolus. Like my break is when my break is. Mm-hmm. And so I tend to eat a little more low carb there just to try and maintain. But no, we don't adhere to a low carb.
Okay.
I have just really tried to embrace what you teach on the podcast. And I actually have a friend who's, likely going to get a diagnosis in the next few days. And he's started listening as well. I recommended it. I said, there's just so much they're not going to teach you in class. There's not time, but there's also just, you have to teach to the very minimal, the lowest, the person coming in with the least amount of knowledge, and you're starting with a much higher knowledge. So just embracing, trying to do better on your own.
I didn't know this was going to be a story about how terrific I was, or I would have gotten to it sooner.
Yeah, no.
Wait, how long have you been listening to the podcast?
Somebody recommended it pretty quickly to diagnosis. I would say within the first 4 months. And so I tend to focus more on the episodes of management versus storytelling, I guess. But I mean, nobody taught me about pre-bolus or protein or any of those things in education. It was carb counting, and which is a great foundation, a great place to start.
Mm-hmm. Well, I'm thrilled. And listen, if you aren't the kind of person who likes a podcast for the chatting, like I get that. I support both sides of that coin with the other. I put all that, I think, great management content in there because everybody wants that, on one level or another. But there are plenty of people who love the stories and they get a lot of community out of it and a lot of good feeling out of it. So I figure if we offer kind of a 50-50 of that, you kind of make both sides of that coin happy.
I love it.
Yeah. So I'm thrilled about it. I mean, before we started recording, I mentioned something from another episode and you were like, oh, I haven't heard that. But be honest, you wish you did, don't you?
Oh, absolutely. Okay. I'm going to go find it.
Well, no. No, you're not allowed. You can only listen to the management stuff. I seriously didn't know that the podcast was valuable for you and had been. So that's fantastic. So pro tip series, that kind of stuff, real helpful.
Yeah, exactly. The
Great.
bold beginnings. You know, the one episode that really rung true was just being diagnosed as an adult. And while there weren't tons of management tips that I went away with, I remember being like, my life was flipped. I felt seen. My life has been completely flipped upside down. And I remember just feeling part of a community and seen at that moment. Like, yeah, this is hard and no one really understands it.
Yeah. See, now I could call this episode Princess of Bel Air. I don't know. I love Gas Passer though. It's going to be hard to get away from that for me. Yeah.
I'll take it.
Yeah. So all this knowledge that you have about diabetes has informed your work. And that's why you're really here. I want to talk about that. So can you just kind of open up about that for me and fill me in?
Sure. Feel free to slow me down if I get going too fast.
Don't worry.
I'm going to touch quickly back to when I talked about nursing school. When I went to nursing school, which, like I said, was the late 90s, the fast acting into the Novolog and Humalog had just been patented and they were not part of education at all. They weren't even rapidly adopted. So we were learning about MPH and 70-30 and regular insulin and managing diabetes from you take this insulin here and you eat exactly 4 hours later, because that's the peak that we're talking about. Glargine was barely being adopted into practice. And so that's part of being like, oh, you really had no freedom to eat then because you were trying to match an insulin profile that had nowhere close to a carb uptake profile. So moving forward, a lot of people my age, which make up a huge chunk of medical providers, right? The 40 crowd, you've graduated residency or you've gotten your master's or you're a nurse at the bedside, but you haven't yet retired, are part of this group that went through education that didn't ever even learn about Humalog and Novolog as part of our basic education, let alone Glargine. So now you come to today where upwards of 60, in the 96, less than 1% of patients were using an insulin pump. We knew they existed. They were like the Zach Morris cell phone attached to your waistband, but people weren't using them because what's the point in continuous infusion of regular insulin sub-Q? So now we fast forward to upwards of 60% of type 1 patients are using insulin pumps, and none of us ever learned about these devices, let alone that they only have rapid acting insulin. We never talked about basal bolus insulin because that wasn't really how insulin was given back in the day. You had sort of insulin that you had to eat to protect the peak so that you didn't bottom out. So when you come in with an insulin pump that someone's unfamiliar with, their gut is sort of like, I don't want to deal with that. What they're not recognizing is if you take an insulin pump from a type 1 patient, you have removed all basal or background insulin. And it's not the standard of care, but I think it's hard to re-educate everyone on the technology today in one mass.
I mean, I guess the basic problem is that people are where they were taught. So these physicians, in med school, got one level on one idea. Then they moved out into the world and the world changed and nobody came along and told them. So they're just doing the thing they do, right?
And so specifically, I don't want to toot my own horn or my profession's own horn, but if you think about an anesthesia provider in any sense, they have to be so knowledgeable on hundreds, if not thousands of surgeries and what's going to happen during that time. They have to be knowledgeable on hundreds and thousands of different medical problems and medical history and how anesthesia drugs affect them. And for instance, the top drawer of my anesthesia machine has 25 different drugs just in it. That doesn't even talk about the machine that I can go get almost any drug I want out of in the hallway. So it's just the knowledge base is vast, and trying to keep up on every knowledge, every disease process is difficult. And then you talk about type 1, whose management has drastically changed in the last 30 years.
Yeah.
It's crazy.
You have those drugs because there could be drug interactions that you have to counteract, and that's what they're there for. Is that right?
Yeah. So almost every anesthetic drug is what's called a cardiac depressant. So your blood pressure drops. You may have those things, so we have to have counteract, or your heart rate may be fast, or it may be slow, or you may need pain medicine, or you may need pain medicines that not narcotic, or this particular surgical procedure, causes less blood to come back to the heart. So we need to supplement that with a different type of IV fluid. It's just a complex thing. So then you have someone who for years came in with either this background of regular insulin or MPH as their basal. Mm-hmm. Then we moved to glargine, which is beautiful for a MDI because it really does have almost 24 hours. So you didn't have to do anything. You were like, you took that, check. Okay, I don't need to give you insulin. It's taken care of.
Right.
And so now we have to come back to many hospital policies say your insulin pump is not allowed in the OR. And while patients are advocating for themselves to take to their pump to the OR, it would be against policy. So then it becomes removed at some point in the beginning in the pre-op area. But are we replacing that with, the big question is, are we replacing your basal insulin? And we need to be. That's the standard of care. So how do we do that in the perioperative period? There's really only two ways to do it. And that is to allow the insulin pump to run if it's within hospital policy, mm-hmm. or you need to start an IV insulin infusion.
Why would they not want the pump to stay on?
Well, turns out anesthesia providers know nothing about an insulin pump. Like I could hand my insulin pump to my friend and it'd be difficult for them to figure out, maybe not difficult, it would make them uncomfortable to try and bolus from a pump. Mm-hmm. Also, during surgery, you tend to get steroids. There's a stress response. Fasting in and of itself can so the risk of hyperglycemia is actually higher during surgery than hypoglycemia. So to have to bolus from that would not be something in the wheelhouse of an anesthesia provider. They've probably never done it. It's not to say they can't learn. The reality is it's unlikely that they've ever done that. And two, it's a very dynamic period. So your blood sugar could change rapidly up or down. More often than not, it's up. And when you bolus from a pump, as we all know, it takes time, right? So it's sort of behind. And then you have a change in blood pressure and perfusion to your sub-Q tissue if your blood pressure is low, if you're cold, if you're warm. So it's a lot less predictable to give sub-Q insulin in the perioperative period versus IV insulin, if that makes sense. Mm-hmm. Though we are starting to see studies come out with very good results for insulin pumps in especially like your smaller everyday run-of-the-mill surgeries versus your bigger surgeries that have high-dose steroids or dramatic fluid shifts. The data doesn't exist, so adopting a pump too is like, I think it'll work fine, but there's very few controlled studies on insulin pumps because we're not a very populous group of humans.
Sure. Oh, so I get it. I understand how we get to where we are. What do people need to do to use them? Like, what could I do going into a surgery to say to someone, look, this pump, I'll make sure that it's new, that it won't run out, but it's not so new that it's not working. I'll put it on 12 hours before the surgery, make sure it's nice and settled in and it's working well. I'll come in, show you where you can push the buttons if you have to shut it off. But in the end, I mean, it's just an insulin pump. Like if it was really, I don't know what they're concerned about, but if you were getting really low, they could just rip it off you. It's not like, you know what I mean? It's not like not knowing how to push the buttons would stop you from stopping it if you needed to. It's just, Courtney, it feels like there's a lot of not thinking that happens around stuff like this.
Sometimes. Mm-hmm. And I feel strongly that we're missing an opportunity to embrace more insulin pump usage. And in fact, like the Anesthesia Patient Safety Foundation put out a piece a couple years ago advocating for more use. And there's some interesting studies coming. There was a really fascinating one out of Switzerland that they put insulin pumps on a large group of type 2 patients that utilized insulin. And they had far better control with less hypoglycemia. Shocking. They put it on in pre-op and they wore it their entire hospital stay. So the data is starting to leak out. I guess my concern is I think if an anesthesia provider feels good about the insulin pump, the surgical site is far from the insulin pump site. So if you're having an operation on your belly, you really should probably have your insulin pump on your leg if you want to have any hope of it staying.
Yeah. I mean, geez, do people not think about stuff like that?
You would be so surprised at the things sometimes you see. And I think that's the other reason. You have somebody who comes in and rides their pump in a way that is probably, their A1C is still 11. And you're like, this really isn't doing a great job for you. And then you have someone like me and lots of your listeners who come in with super tight control and are very knowledgeable, but you don't know who you have in a 10-minute interaction necessarily.
No, I understand. Also, it wouldn't take that much more insulin to turn an 11 A1C into an 8 A1C, and you still wouldn't be really tightly controlled. But it's, well, I mean, listen, that goes to show what it shines a light on is the vicious circle. There is just no reason in the world that a person should have an insulin pump and an A1C of 11. That's somebody not understanding fundamentally how to use their insulin. And a doctor should be able to step in and give them the information that they need.
True. Yes.
It's not that hard. So then what it points to is either a person who doesn't understand or is unmotivated or somewhere in between that scale, having diabetes, showing up in a hospital where another doctor looks and says, oh, an 11 A1C, you don't even try. You don't even care. So then you kind of get written off at that point. You know what I mean? Like you shouldn't have to be you coming in going, I have a 5.2 A1C and I really know what I'm doing. It's okay if we take good care of me here.
Yeah.
Yeah. You know what I'm saying? Why don't we take good care of everybody? Crazy thought. Some people just aren't going to know. You've just explained why. A long time ago, that's not really that long ago, there weren't insulins that worked as well as the ones that do today. The standard of care was much different. There are still people out in the space who grew up with that, and there are people who are learning from those people. So that's why you can't get rid of it. You would just think if a generation of doctors would just retire, it would be okay. But that's not that's not going to work. Not completely.
No.
Yeah. So I don't know. It's hard to hear about. You know what I mean?
So I guess at the end of the day, I think if we want to provide safe care in the perioperative period, I want people to understand that basal insulin is not an option. It is a requirement. And so for patients on MDI who took their long-acting insulin, it's often simpler for us anesthesia people. Basal insulin requirements are met, right? We should be checking blood sugar every hour and treating hyperglycemia and hypoglycemia appropriately. Mm-hmm. If a patient comes in with an insulin pump, I think I have to say you need to work within your hospital's policy. My hospital allows patients to keep their insulin pumps for day surgeries, but those surgeries that are going to the ICU or bigger surgeries, they want their insulin pumps removed until the patient is awake and can restart them. And in those cases, our hospital dictates that you start an IV insulin infusion at the basal rate that's set in the pump. So we are meeting basal insulin requirements, and then we have a glycemic team meets with the patient postoperatively. And some patients are MPO or they're going to be on high-dose steroids, and it's just easier to stay on an IV insulin infusion for a few days. And sometimes they move them right back to the pump inpatient.
Does the IV insulin give you insane control?
So the difference with IV insulin versus a sub-Q insulin is it's IV. So all IV insulin is regular insulin. So the same regular that people sometimes inject back in the day, but some of the low-carb people, I think, advocate for that still. But it is a completely different profile when you inject it IV. So its half-life is 7 minutes. So if you're running high, I can give you a bolus of insulin and it is acting within 7 to 15 minutes. And so then it's also completely gone. We say things about 7 half-lives. You can consider a drug kind of out of your system. So if you were hypoglycemic on an IV insulin infusion and I turned it off or cut it in half, it would be gone within an hour. So we're dealing with we're dealing with a drug that can react far faster to the changing glycemic environment of surgery. So while I think we're missing opportunities to move forward with insulin pumps in multiple cases, I don't think every case can be done with an insulin pump. And I think we can safely use IV insulin. My big thing is we need to start IV insulin. And so some patients, unfortunately, do get removed from their insulin pump, and you hear horror stories. And then they gave me a bolus of insulin through the IV because I got hyperglycemic. Well, no shit. Mm-hmm. Yeah, you had no basal. It'd be like a site going bad or whatever. Right. And then they see your blood sugar at 200. So they give you a unit IV. Well, it works to drop you down to 180, but it's gone again.
In an hour.
In less than, it's affected. The site is probably even less than that. So then they recheck and they're like, oh, you're 200 again. And you're like, well, yeah.
I don't have any insulin. So, my pancreas doesn't do anything. I mean, it does some stuff, but it doesn't do insulin anymore.
Yeah. So the patient comes out and it's like, what the hell? And I'm like, exactly. And so I've given a couple lectures on this topic. And my girlfriend the other day was like, you should change it from type 1 diabetes in the perioperative period to it's basal, baby. And like, that's just your mission. Does the patient have basal insulin? Does the patient have basal insulin? Like, that should be what my hat says, not gas passer, but does your patient have basal insulin?
But Courtney, is the way you're talking about this right now from a professional perspective, is it only because you got type 1 diabetes 5 years ago? Like, how would you have talked about this 7 years ago?
Totally different. So there's about 5% of all patients with diabetes have type 1. So I like to look at the flip side of that, meaning 95% of patients with diabetes do not have type 1. And so I think that's a common thing is people get diabetes, which I really want them to have two different names, but so that the confusion is less. But patients come in with type 2 and we think about that different, right? They have insulin production. Their risk of DKA and acidosis is far lower during the surgical period than somebody with type 1. And I absolutely would, like, if an insulin pump came in, it gave me like a quiver in my gut. I'm like, I don't know what to do with that. And then every time it was like, okay, I have to look it up. Do I keep it? What do I do? And so I think people, I really, really think of many professionals don't realize that the insulin pump has only rapid acting insulin and that they're taking no basal insulin. Mm-hmm. And so that's where the mistake happens. I think I fell into that idea of like, oh, it's not regular insulin. Oh, that's weird. And then learning that once I was just like, the second I was diagnosed, I'm like, I want a pump and I want a CGM. And they're like, well, your insurance is going to make you wait for your pump, but you can get a CGM tomorrow. And I remember learning about my pump in the 6 months I had to wait. And I was like, oh, it's not, I get rid of glargine. I'm like, holy cow. Like, that was a moment for me. And it's sort of embarrassing to admit that I didn't even recognize that. Yeah. And so I think that's a big part of why I'm here. I'm like, it's embarrassing what I didn't know. And I also watch other people not know that.
I think that it's the most disappointing thing I'm going to hear in the next 4 days. Honestly, just the idea that a medical professional might not understand that basic idea about how an insulin pump functions. That's really like, because you have to put yourself in a position of someone who's just going to the hospital to have their, have their gallbladder out.
That's why this is super, important conversation.
Oh, 100%.
Is that I do think that knowledge deficit exists, unfortunately. And I think someone coming in to have surgery and has been told that their insulin pump needs to be removed, I want them to have the words to be like, that's my only basal insulin. So what are you going to do to provide me basal insulin while I'm in surgery? But
don't you think that people have a reasonable expectation that's not a thing they have to say? Yeah, Courtney, if you went to take your car to get 4 new tires on it, do you think the last thing you should say to the guy at the counter when you hand him the keys is, please tighten the lug nuts back up when you're done?
I mean, yes, but right? I'm not defending
No, I know you're not. I'm not calling you. I'm just saying, I'm just having a conversation with you. But like, I'm trying to put the conversation, not you, in the perspective of everyone else who has no reason in the world to expect that a medical professional wouldn't understand how an insulin pump worked. You know what I mean? Like, I understand your description of why that's the case, and I'm not even arguing with it. It makes complete sense to me. I'm just saying that if you're just like, I was going to say Joe Blow. Do people say that anymore? If you're just the average guy on the street, what does Joe Blow even mean? We'll look into it later, Courtney. If you're just an average guy on the street going in for a procedure, you're probably not thinking about it because you're probably worried about having your appendix out or something like that. But at the same time, like, I'm at the doctor building now with all the doctor people in it. This is a medical thing. My device is a medical thing. They'll know. Like, I don't even think it gets to they'll know. I don't think you even think about it. That's my point. Like, so I know people have to, that's why it's important to talk about this for people with diabetes. They need to go in there without acting like a lunatic or seeming strange and say, hey, who do I talk to and explain this insulin pump? And then you know what happens when you say that? Somebody's going to want to reassure you. That's a famous thing in all professions.
Oh, absolutely.
Oh, no, we know what we're doing. Sure you do. I don't know 10. Let me just say this now. I want to be clear. I don't know 10 people that know what the f they're doing. Okay. Like forget about medicine in my life. I mean, I know a few people who have got everything together, but I know way more people who would say, oh no, don't worry. I got it. When what their brain is thinking is, I don't know what I'm doing. So it's human nature. You know what I mean?
No, I agree. But I also think I'm not. Yes, I think people come in and expect people to be knowledgeable, and I want them to be knowledgeable, and I believe that they should be.
How do we do that then?
I mean, I'm doing my best. I'm talking to you. I've lectured multiple times, and I don't have a great answer. Is
there not continuing education in the facility? Do all the gas passers not get together once a week for a 15-minute lecture on something? Or is there not an email that goes around that says, hey, don't forget insulin pumps work like this? And then why is that not a thing? Wouldn't that be so simple?
It is a thing.
Oh,
it is a thing.
Oh, geez.
But
so you tell me that
everywhere. I work at a huge academic institution, right? So we are very geared towards education. So I lecture at my own institution to our residents once a year. So their first year, here's this. I've given full grand rounds where I just went through everything type 1 related, including CGMs and insulin pumps. And then I talk about insulin pumps, usually about for 15 minutes on what we call a CQI meeting, which is also grand rounds. But we go through like, hey, we're not doing this great. You need to do this every time. Here's our policy. This is what you need to be doing. So that exists in my institution. It does not exist throughout, we have places that, are tiny. They're one anesthesia provider. And to try and stay up on every last detail in medicine is difficult because anesthesia touches in every, high blood pressure, stroke, blood clots, cancer, and then the surgeries that go along with it. I'm not justifying not having the knowledge base, but staying on top of every single change in medicine is not. I
want to do an exercise
easy.
with you, Courtney. Tell me again, what is your actual job title?
I'm a CRNA or a nurse anesthetist.
All right. Spell anesthetist for me.
My Dexcom's going off. Did you hear it?
Don't be sorry.
It's ANETHIST.
Okay. Here's what I'm going to do. Because I think the world's simpler than we make it.
Okay.
I'm going to ask ChatGPT, explain how an insulin pump works to an anesthetist. Say that again. Wait, how come it's spelled like that? Why does nothing like me today? Anesthetist.
Or you could say anesthesiologist. It's all... I have a different path to education, but we both provide anesthesia at the head of the bed.
All right, let's do that. Hold on a second, because that I can spell. Include what they need to know about managing a person with type 1 diabetes. I've never done this before in my life.
Okay.
An insulin pump is a medical device used to manage diabetes, specifically type 1 diabetes, which is characterized by the body's inability to produce insulin. Insulin is a hormone. Hold on a second. It is not stopping. Insulin is a hormone that regulates blood sugar levels by allowing cells to absorb glucose for energy. In type 1 diabetes, the pancreas does not produce enough or any insulin, requiring external insulin administration to maintain proper blood sugar levels. Here's how an insulin pump works and what an anesthesiologist should know about managing a person with type 1 diabetes. And it lists function of the insulin pump, continuous insulin delivery, bolus dosing, adjustments during surgery, and monitoring. Adjustments during surgery or any medical procedure requiring anesthesia it is important for the anesthesiologist to communicate with the patient about their insulin pump. Depending on the duration and type of procedure, adjustments may need to be made to the pump settings. For instance, the basal rate may need to be temporarily reduced or suspended to prevent hypoglycemia or low blood sugar. Okay, that's a browser window on my computer, Courtney.
Yes.
Like, how come someone can't do that and go, oh, I'll be in charge of sending out the daily reminders to everybody? Like, I mean, did I just fix the whole world? Do you see what I'm saying? Like, I love how everybody says, oh, this is how it is, or here's how we got here, or it's so hard to fix. It's not that hard to fix. One focused person could fix this in every hospital. Do you know what I mean? Am I being shitty? I don't know if I am.
No,
or not.
You're not being
okay.
shitty.
Okay.
What I'm going to say is I tend to be that person a little bit. People come to me. I have
but that's only because we all got lucky and you got type 1 diabetes.
But what I'm saying is, even as somebody who tirelessly advocates, I can't force someone to absorb that information.
Let me say this to those people. Do your job. There. Okay? Like, you're getting paid. You know what I mean? Like, just do the thing you're being... I don't know. I get very upset, Courtney. See, you're even-keeled, which is lovely for the conversation. But this seems so basic to me. And the fact that it has to be rehashed over and over and over again, and that a person like yourself has to get type 1 diabetes and take it upon themselves to educate other people in a professional setting, none of that makes any worldly sense. It feels like to me that people see problems and then go, oh, problems, instead of going, oh, that's a problem. Why don't we make an adjustment so it doesn't happen again? Like, because this is not a new story. You could put a whiteboard up in a room and say to the anesthesiologists, which I can spell, you could say to them, there's a marker in there. Every speed bump we hit for a month, we're going to write it down. And then we're going to create a list of things that happen most frequently. And then we're going to go ask ChatGPT to explain it to us all. And then we're going to put it out into an email. And it is part of your job to read the email. And that's that. Like, I mean, honestly, this is 45 days worth of effort. Fix everything. I don't know. That's the part that confuses me all the time. Why do smart people not do smart things?
I mean, those things happen, right? Those happen all over the country that we talk about these things. But
then how does it keep happening then? You're just saying it's a failing of human beings?
So if you think about, I mean, yes, it's a fail of human beings, right? We all forget things day in and day out. I mean, half the time I forget my anniversary, right? Which it's got a long, that's part of my job as a wife. I'm not saying it's acceptable. I'm saying we're human, and our brains, I will tell you, in healthcare are bombarded constantly with emails of how we can do better, what we did wrong. And I would tell you that failing on an insulin pump would not show up on that whiteboard. Why? Because they're extremely rare. Even though we deal in this community where they seem like everyday things, the fact that that person makes it to surgery with their insulin pump is,
still rare for you.
Extremely rare. Yeah. So maybe we see one insulin pump through my institution that staffs 50 plus operating rooms a day and anesthetizing site. Maybe we see one, and we have 167 people providing anesthesia or more. You may see an insulin pump on a patient once every 2 or 3 years.
Yeah. Well, listen, Courtney, between you and I, some of you motherfuckers wouldn't want to work for me. That's all I'm saying. I'd fire you. So that's all. There'd be no one left. I'd be like, you're gone. Did you read the email? No, goodbye. And like, I just think, go ahead. How are you going to improve? People, can I say something about people?
Yeah.
I don't think they really want to work.
Oh, I mean, right? I win Powerball. I'm out.
I think everybody wants to like get up around 11, move into the day slowly, maybe hit their bong, have a little lunch. You know what I mean? Maybe watch a Netflix. Who knows? And then ease into the evening and you're on your way. Like, I get it. Like, it sucks. It's a lot. I don't mean to be flippant about it. It's a lot to remember. There's a scarcity of how many times it happens, which makes it, I imagine, even more difficult to remember. It still happens.
It does.
It feels to me like there's a hole in my backyard. I only walk in my backyard every few weeks, but somehow I fall in the goddamn hole every time I go out there. And no one goes, hey, we should put a sign next to that hole, or let's get crazy and fill it in. That to me is what it feels like. Like, I know it's not often. I know it's kind of silly. I know it feels like a thing you should be able to remember, and it doesn't need to be addressed. But I don't know how long we have to live and watch the same thing happen over and over again before someone says, hey, you know what? This is a problem. Listen, I'll ask you. Let's take diabetes out of it for a second. Are there other topics specific to your profession that reoccur all the time that are an issue?
Well, let me just clarify. Yeah. I want to say that this does not happen every single time, but I do think it does happen. I hear about all the mistakes because people ask me how to fix them. I never hear, hey, my anesthesia provider nailed it.
Right? God bless. I was put under 6 months ago. It went perfectly. But that's not, I mean, listen, that's not a thing we have to talk about. Like, we're all adults. We don't need to be celebrated for doing it right. I hope not.
Right.
But I take your point. We're not saying everybody is in this situation. It's not going to happen every time. It's not going to happen to every institution. I'm not saying that either, but we're just drilling down on the problem. So, okay, let's lighten this up for a second.
Okay.
We have like 10 minutes left, and I have a real serious interest here. First, let me ask you, do you think we got through everything you wanted to talk about?
I mean, I think if I had to say one thing to any health provider, like anesthesia provider listening, if they're listening, they already know this, but they have to have basal. You know, I'm not going to tell you to go against your hospital policy and leave an insulin pump running. If that's not in your hospital policy, start an IV insulin infusion. There are plenty of journal articles that talk about, and I'm happy to send you a link, Scott, if you want to put it in the notes, to the one that I think is the most comprehensive.
Please do.
Insulin pumps have not been well studied in the anesthesia literature. There are studies that say, I think you can use them safely. There's not one study that says this is the end all be all. What the literature does say is you have to provide basal insulin. It's about the basal insulin. And I would encourage any patient going into surgery to know their pump settings so that you can communicate clearly, and know that if your pump is being removed, to advocate for basal insulin. You may be falling on, repeating what somebody already knows, but just say, my understanding is if you remove my pump, I should be started on IV insulin at my basal rate.
Yeah.
Is that your plan? That, I think oftentimes patients, don't think to have that conversation, but there's still something intimidating about medical providers. They're the knowledgeable ones and we're not, but I think it is perfectly acceptable to advocate for yourself.
Okay.
In any way, shape, or form, especially in a way that's open to conversation, in the sense that you're not attacking someone. Just say,
right.
Everything I've ever read is if you remove me from my insulin pump, I should be started on IV insulin before you remove it. So is that our plan? Mm-hmm. And I can give you a copy of this for, bring it in with you. I'm, just if you avoid one time where you have a hiccup.
It's valuable. For sure.
It's valuable.
Yeah, and know what you're talking about. Don't just go in and say, hey, fix this for me. You have to have some information about what is working well for you as well. Because the doctor's not going to, I mean, in that situation, like somebody in Courtney's position is not going to sit down and help you figure out that your basal's too strong or too weak or something to that effect.
Yeah, I mean, our recommendation, if we remove the pump, we're starting to use a tool called EndoTool, which is sort of like Control IQ or Omnipod 5 insulin decision algorithm that it relies on the provider to input the data and then into a computer program. And it tells us at what rate to run insulin and how often to check the blood sugar to make adjustments.
That's where this stuff is headed, right, Courtney? Like eventually you'll be a technician and a computer will decide what to do.
Yeah. So it tells me its best guess. And then we're moving towards that, an algorithm that helps learn the patient and make decisions based on the patient.
Yeah.
Anybody being removed from an insulin pump should have basal insulin in some form. And that in the perioperative period, the most recommended by far is IV insulin infusion at the patient's basal rate in the pump. Mm-hmm. And so Omnipod 5, you're probably going to have to, it's not a set rate, right? So that we run into that problem. Even people doing it right, they're like, I have to remove your pump for this reason. And the patient's like, I don't know what my basal is. So maybe take a little time.
Yeah, because I'm on an algorithm.
And figure out what kind of your pump is running at basal wise. You're going to have to do some calculations or dig a little bit deeper, but that will really help your anesthesia provider as well to be like, if you're removing that, this is where I would start. And then sometimes we recommend like an exercise mode if you are keeping your pump, especially for a short surgery, because we as anesthesia people are deathly afraid of hypoglycemia. It's rare during surgery.
Is it a bigger problem because I'm unconscious already?
It's not a bigger problem. It is not more common, but it unrecognized hypoglycemia. So you would say, I feel like, and we would do something. We'd check your blood sugar, but no one's there to say, I feel like. So it relies on an anesthesia provider checking your blood sugar at a regular rate. At very minimum is once an hour.
Literally with a finger stick.
Yes.
Yeah. So what we really want is people to wear a CGM during a surgery. That would be really valuable.
So CGMs are not validated in the hospital. Any patient of mine got an FDA approval during COVID, an emergency FDA approval, which was really fascinating. Some of the literature that came out of that, like how they were used. And I think there's going to be a data spill that probably comes out. My hospital's policy on CGMs is the patient may wear their CGM and I may use it as a trending device, but at minimum, I have to use a finger stick machine in surgery at least once an hour.
Yeah, that's fair enough. Plus, you really want to charge them the $50 for the test strip. So,
true story. And the data is signal loss is common on CGMs. And if they're not in the surgical field, you should ground away from them. They've never, again, been well studied in the operating room. So the Bovie pad and the grounding is always a question mark because you're putting metal, you have metal in the patient's skin and, it's coated in plastic, but sitting on top for the Dexcom. But I think you could advocate to leave it on even if your anesthesia provider chooses not to use it. I never make somebody remove it because they're expensive. And I know that. And I've tried to educate people on that. But advocate for yourself.
I have a story about what I did for Arden once that I'm not going to add here because I think it'll take away from people believing in me in this conversation. But I remotely managed Arden's insulin during an exploratory surgery once. So, and they didn't know I was doing that. But, Wi-Fi, it's all magical.
Yeah.
Now, here's my question, right? Because how I want to finish up, because I really appreciate you doing this. First, I want to thank you very much for lending your expertise and your knowledge in this blend of you having type 1 with your years and years of service as an anesthesiologist. That's really valuable. And thank you. I'm actually going to make this episode a part of my Grand Rounds series. So now I can't call it, maybe I'll just call it Grand Rounds Gas Passer. I'm probably going to say anesthesiology, normal. But here's my question. I've been out a number of times, right? I've had colonoscopy. They make you sleepy for that. I've had my knee scoped and cleaned out. I've had a surgery in my toe. They give me what they call the Jackson juice. That's propofol, right? Is that what that is?
Yep.
I want to understand the mechanics of that. And I'm going to start by asking, if you get a bad is not the right word, but if you get an anesthesiologist that doesn't know, it burns like a motherfucker going in. And the last thing you remember before you're gone is, why does my arm burn? Oh my God, my chest burned. And then you wake up and it's over. But I had another anesthesiologist. I told him, I said, hey, the last time I got this, it burned really bad in my chest. And he goes, oh, don't worry, I can fix that. And then I think he tourniqueted my arm and held it there for so tell me all about that. Like, first of all, how do you get it in without it burning?
Okay. So there's no guarantee. But propofol is very alkaline, and so then it causes a pH change, and it makes your vein really angry, and it burns like a mother, like you said.
It really does.
So most anesthesia providers, especially for a general anesthetic, so in the operating room, numb up your vein with lidocaine, IV lidocaine, so numbing medicine.
Oh, that was all he did? Oh, okay. And then, but he holds it there for a minute, right? That's how he like the lidocaine goes in. Did he tourniquet my arm? I'm trying to remember what happened.
So we say there's a lot of science and a lot of art in anesthesia. And so that is one of the art things. Some people believe if you put a tourniquet and put lidocaine in there, it has a chance to numb longer because that blood is not moving away from the site.
Oh.
Other people just believe the act of giving lidocaine before and kind of with the propofol is enough.
I got to tell you,
sometimes
it worked
despite
like magic.
Everything we do,
it doesn't work.
I always tell people, it's spicy. I'm sorry. I'm doing my best to make it not.
Yeah.
But that is completely normal and it's going to be gone when you wake up.
Yeah. So then,
So,
okay.
yes.
So that, first of all, I wanted people to know that in case they ever can ask for it. But the rest of my question is, what is the mechanics of it? Like, how is it shutting me off like that? Because it happens it's less than 10 seconds.
So it works on a GABA receptor in your brain, which is a receptor that can cause this sort of sedation, and then it hyperactivating it makes you go to sleep. But don't ask me how anesthesia gas works, because we don't really know. We have theories, but we don't. And so that's usually you go to sleep with propofol, and most anesthetics, you're kept asleep with anesthesia gas once the propofol works. Propofol just works so fast that's how we call the induction of anesthesia.
So you put me out with the propofol, then you keep me out with something else.
Typically.
Yeah. All right, then you back it off and I wake up. But this is why I asked the question, because I know this, and I just wanted I wanted to know if I was right or not from what I had heard. But medicine doesn't actually know why it works, right?
We have a much better idea on propofol, but the anesthesia gas we do not know.
Isn't that fantastic? Like, we can shut people off and turn them back on, and we don't really know how it's exactly happening. That's insane.
We know the dose, we know what's appropriate, but we don't.
Fucking crazy, Courtney, isn't it?
It's crazy. Yeah.
It's like magic.
I mean, it's like, I love my job.
Yeah.
Like, it is the coolest job. I get to practice medicine at a like cellular level. Like, I'm giving this drug that I know which receptor it works on, and I know what should happen when I give that. But
you're
I also have
biohacking
this
to some
huge
degree.
Mystery in front of me too.
Yeah.
And humans are, medicine is, you can do everything right and things go wrong, and you can do everything wrong and things go right.
Yeah.
I have a really cool job, but it is definitely stressful at times.
Hey, have you ever, I don't know if this is something you'd want to talk about or not, but have you ever put somebody out that didn't come back?
I work at a trauma center, so yeah.
That does happen. Yeah. Oh, wow, that's crazy.
I mean, it is extremely, extremely rare for somebody to die on the operating room table.
Mm-hmm.
You have some of the most experienced emergency managers in the hospital there, and we have a lot of drugs on hand. It's extremely rare to die in the operating room, but it happens.
I tried to remind myself the last time I just had my toe fixed, right? And before I went under, I said to myself, I'm like, when you wake up, blurt out, "Not today, Jesus," right? But I didn't remember to. So, like,
you're like on the way home and you're like, crap.
I forgot to do it because it's a room full of
anesthesia wins again.
Oh, there's a room full of nurses there and they're all sitting around charting and everything. And I was like, how great would it be if I just burst awake and I was like, "Not today, Jesus." But I, you're very out of it when you first start waking up. So, but also fascinating how quickly you're not out of it afterwards.
I know. I love it when it's a sign of a good anesthetic when I'm wheeling into the recovery room and the patient's like, "Wait, we're done?"
Yeah.
Like, it happened. And I'm like, "Yeah." And they're like, "But I'm awake."
It's the best nap too. It really is. I wake up very relaxed afterwards. Like, I'm like, oh, the rest of my day is going to be fantastic. Anyway, I see what happened to Michael Jackson. I honestly, I see how we could get hooked on it. If he had trouble sleeping and had access to a shady doctor, like, I get it. You know what I mean? Like, Jesus. I really appreciate you talking about this. I appreciate you going over that with him. I'm not much of a geek about stuff like this usually, but this one really is fascinating. Like, we are shutting people off in a medical situation and we do not actually know why it's working. Like, that's fascinating,
It's sort of, it's like one of those things that like probably wouldn't get FDA cleared today. They'd be like, figure it out. But it's been around and used safely for so long that you're like, all right.
Yeah. They say peanut butter is one of those things. Did you know that?
No.
They don't think peanut butter could get through the FDA today?
I mean, that would be a sad day.
I don't want to freak anybody out, but don't Google why.
Okay. We actually in our break room, we have peanut butter for when you're just running behind and you need a quick snack. And I eat a lot of peanut butter. Mm-hmm. But they switched over to the natural little cups. And I was...
Where's the sugar?
Really,
come on, Courtney.
I'm like, it's the oil's on top. And I'm like, I'm trying to eat quick and my cracker doesn't dip in this. It's so
natural. Great. Great. What am I trying to, how am I trying to live to I'm 100? Right, Courtney? The peanut butter can't be a little sweet? What the hell?
I know, or mixed, at least. Anyways.
Blended so that oil's not floating on top of it. Because, you look at it, you're like, this is like sucking on a peanut for a whole day and just squeezing it in my teeth slowly.
I know. I'm sure my patients appreciate the oil spilled down the front of my scrubs when I go introduce
I'm a professional.
myself.
Everything's going to be fine.
We're all good here. We're good.
Anyway, good luck to all of you. We're all live by a wing and a prayer. Just the whole thing's being held together by spit and duct tape. Good luck. But seriously, this was really wonderful. I appreciate your time and your good nature about it. And I got upset in the middle and you stayed even keeled.
No, yeah. I mean, I want everyone to be experts at everything. But at the end of the day, if you're not an expert, just know a type 1 patient needs basal if you take their insulin pump off. And I think, it's pretty rare that things go wrong. But I think that understanding is really an important piece. I could nerd out all day on it.
I agree. Yeah. And Courtney, listen, I'm not a Pollyanna person. Like, I've been making this Cold Wind series, which is healthcare providers are coming on anonymously and talking about their jobs. And now I'm getting notes all the time from people who are like, were you just shocked when they said that? I'm like, no, wait.
You're like, why did I started it for a reason?
Yeah, I started it because I knew what they were going to say. Like, I'm just giving them a platform to say it. And I'm like, you're shocked that this is how the world works? I'm like, oh, that's fascinating. No, I'm not shocked by it. Yeah. So
I will say the vast majority of people in medicine want to do right. And if they don't do right by you, it is not intentional.
I believe
I'm not saying it's not their mistake to own. It's just, I think unless you're really like in it, like the amount that you get bombarded and like the burnout rate is high.
Yeah.
But we do need to own our mistakes and own our knowledge deficits. But I do think there are people out there making the same mistake over and over that need to learn.
Right.
But the vast majority of people really are here for the right reasons.
Courtney, I believe wholeheartedly in what you just said, and that people's good intentions and their desires and everything like that. And when I say like limitations of human beings, I don't mean that pejoratively. It's a limitation. Like, we just can't keep it all straight. We are thinking about going home and watching Netflix. Like, we are like worried about a fight we had with our girlfriend. People are still people. I'm just saying, what happens is that when you come in from the other angle, when you're the patient, you get lulled into this sense that like, it's all going to be fine because the magic man in the white coat's there. It's going to be all right. This lady went to school. Like, I mean, did you get a master's degree for this, you said? Right. And now it's
anesthesia.
And now it's a doctorate.
I have a master's degree in anesthesia, right? I'm not an endocrinologist. And so oftentimes a type 1 patient that comes in to me, obviously I'm worried about their type 1 in a certain way, but we've heard about the side effects of type 1, right? So often people who had poor management at some point in their life have kidney disease, or they have coronary artery disease, or oftentimes your hypertension or your kidney disease is more concerning to me than your type 1.
Yeah.
And because that will affect my anesthetic in that moment far more than your type 1, even if I'm not treating your type 1.
Yeah. See, now my perspective though, Courtney, is because I get to have all these conversations and see all these things come full circle, is back to the vicious circle I brought up before. Like, someone's got to step up and put a stop to this. Like, the idea that people with type 1 are going to have these problems, not everybody, but more of them than we hope. And that begins at diagnosis. That's where my Grand Round series comes from. It begins at diagnosis and having a learned person explaining this to you from step one. And so that you don't end up a person in an ER 30 years from now that you look at and go, oh, I'm more worried about her hypertension than I am about her diabetes. You know what I mean?
Absolutely.
Yeah.
Like, we have the tools now that we shouldn't be living with A1Cs in the 9s.
Right. All right.
Like,
we're going around and around. We
education.
Agree with each other. You and I are a society of people who are like propping each other up.
I wish medicine paid for, like, every few months, like, go home with the basics of carb counting. And then you have another, education appointment. Like, how are we going to do better? Where do you feel like you're lacking? I noticed this, but our healthcare system is not designed for that.
Yeah.
Which is where you come in.
Apparently, it's why I have hey, listen, here's the truth of it. All you shoddy doctors, you're setting me up with a nice life here. You know what I mean? Like, I got this podcast. It helps a lot of people, pays my bills. I should thank you for being so bad at what you're doing. Anyway, I'm just joking. Am I joking, Courtney? A little bit. All right.
A little bit.
Yeah. I'm going to go. Hold on one second for me.
Okay.
The conversation you just heard was sponsored by Dexcom and the Dexcom G7. Learn more and get started today at Dexcom.com/juicebox. Touched by Type 1 sponsored this episode of the Juicebox Podcast. Check them out at touchedbytype1.org on Instagram and Facebook. Give them a follow. Go check out what they're doing. They are helping people with type 1 diabetes in ways you just can't imagine. Mark is an incredible example of what so many experience living with diabetes. You show up for yourself and others every day, never letting diabetes define you. And that is what the Medtronic Champion community is all about. Each of us is strong, and together we're even stronger. To hear more stories from the Medtronic Champion community or to share your own story, visit medtronicdiabetes.com/juicebox. I was looking for a way that we could all get nice and tan and meet each other and spend some time talking about diabetes. How are we going to do that? On a Juice Cruise. Juice Cruise 2025 departs Galveston, Texas on Monday, June 23rd, 2025. It's a 5-night trip through the Western Caribbean, visiting, of course, Galveston, Costa Maya, and Cozumel. I'm going to be there. Erica's going to be there, and we're working on some other special guests. Now, why do we need to be there? Because during the days at sea, we're going to be holding conferences. You can get involved in these talks around type 1 diabetes, and they're going to be Q&As. Plenty of time for everyone to get to talk, ask their questions, and get their questions answered. So if you're looking for a nice adult or family vacation, you want to meet your favorite podcast host, but you can't figure out where Jason Bateman lives, so you'll settle for me. If you want to talk about diabetes, or you know what, maybe you want to meet some people living with type 1, or just get a tan with a bunch of cool people, you can do that on Juice Cruise 2025. Space is limited. Head now to juiceboxpodcast.com and click on that banner. You can find out all about the different cabins that are available to you and register today. Links in the show notes, links at juiceboxpodcast.com. I hope to see you on board. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. If you're not already subscribed or following the podcast in your favorite audio app like Spotify or Apple Podcasts, please do that now. Seriously, just to hit follow or subscribe will really help the show. If you go a little further in Apple Podcasts and set it up so that it downloads all new episodes, I'll be your best friend. And if you leave a 5-star review, I'll probably send you a Christmas card. Would you like a Christmas card? Hey, what's up, everybody? If you've noticed that the podcast sounds better and you're thinking like, how does that happen? What you're hearing is Rob at Wrong Way Recording doing his magic to these files. So if you want him to do his magic to you, wrongwayrecording.com. You got a podcast? You want somebody to edit it? You want Rob.